Good day, everybody. It's wonderful that you can join us for this JBI Live Webinar event. We're really excited to bring this to you today. And thank you for joining us from wherever you are in the world. This is an exciting series, and we're covering a raft of topics, all about amplifying the voice of people who care about, passionate about evidence-based healthcare, and hearing and creating that availability to hear a wide range of voices and people talk about their experience, share their knowledge with one another. It's just after 8 a.m. here in Adelaide, Australia, in JBI headquarters. A good event always starts on time, so we're going to start on time as well. I would just like to, before we move into the more formal proceedings, start by acknowledging that we're delivering this webinar from the lands of the Kaurna people. I'd also like to acknowledge the traditional custodians of the various lands on which everybody who's on this webinar today works, and the Aboriginal and Torres Strait Islander people who are participating in this webinar today as well. We welcome you. And I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures, connections to the lands and waters of Australia. So my name is Craig Lockwood. I'm the Program Director for Implementation Science in JBI. It's my pleasure to welcome you and thank you for joining this live webinar event, a wonderful opportunity for us to engage globally at a time when global engagement is difficult, and to share together some experiences, some knowledge and insights. So thank you for being here. In order to help everybody to get the best out of this webinar, we've had you join in listen only mode. That doesn't mean we don't want to hear from you. We definitely do. So please use the chat function liberally throughout this to talk to each other and to us. If you have questions that are particular for attention to one of our key speakers today, and I'll be introducing them shortly, then please use the Q&A functionality. That way we know that a question is flagged for our attention in particular. If you have friends or colleagues that couldn't make it today, then this will go up on the JBI YouTube channel. And of course, you can watch it at any time from there. And just to say, we do really value and appreciate your feedback on these events. A lot of people have started using online presentation forms, but there's always room for growth and improvement, and also for positive feedback. So if you have any of that, feel free to send that feedback through to jbieducation@adelaide.edu.au as well. We'd love to hear from you. Of course, we do live in this electronic age. It's all about social media and Twitter. If you want your tweet to be seen and to be heard, and if you want to amplify the message of anything that you're tweeting today, please use the two hashtags that you can see on screen now, JBI Live and World EBHC Day. So those are the key hashtags to use. And you can see also the groups and individuals to use the @tag with. So Professor Ian Graham, Bianca Pilla, JBI and World EBHC Day. This will ensure that all of the global partners that are involved in World EBHC Day do get to hear about what you have to say or what your experiences have been. But now it's my very real pleasure to introduce Professor Ian Graham to you. For many, he'll be familiar speaker that you've heard before. Professor Ian Graham is PhD, FCAHS, FNYAM, FRSC. He's Professor in the School of Epidemiology and Public Health and the School of Nursing at the University of Ottawa. He's an honorary professor at Deakin and a senior scientist in the Clinical Epidemiology program at the Ottawa Hospital Research Institute. And obviously his research program focuses on knowledge translation. There's a lot more I could say, but you're not here to hear me, you're here to hear Ian. So I will hand over to Ian now. Thank you very much, Ian.
Thank you, Dr. Lockwood. And I'd like to acknowledge that I work and live on the unceded ancestral territory of the Algonquin First Nation in Ottawa. Thank you for that introduction, and thank you to Professor Munn for inviting me to talk on World Evidence-Based Healthcare Day. I never would have thought to have given a talk on casebooks. So I appreciate the suggestion to do that. And I'm not sure what the right salutation is since this is the first one, but I guess it's Happy World Evidence-Based Healthcare Day. So there's a few things that you probably need to know about me. I was on the JBI advisory board for several years. I was the Vice President of Knowledge Translation at the Canadian Institutes of Health Research, which is the Canadian health research funding body like the NHMRC in the UK. I've been involved in implementation science and knowledge translation research. And my current grant is actually on what we call integrated knowledge translation. And I'll mention what that is in a moment, but research co-production and studying it. And you'll see why that becomes relevant later on. So over the next half hour or so, I'd like to define some terms, tell you about what casebooks are and how to produce them, describe my experience with them, provide an example, a current example, and ideally, my objective or the session objective is to have you reflect on transforming tacit knowledge about implementation and impact into explicit knowledge so as to better influence practice and policy. So when I think about evidence-based healthcare, I think of two critical components. One, high quality synthesized evidence that addresses healthcare needs, so the knowledge that needs to be implemented or translated, and then implementation or use of that evidence. And that requires systems and structures and expertise for mobilizing the knowledge into action. And so this is where I think casebooks may have a small role to play. So according to Merriam-Webster, a casebook is a book containing records of illustrative cases that are used for reference and instruction, so fairly straightforward. Tacit knowledge, which you may be aware of, is knowledge, skills, and abilities of that an individual gains through experience. And the definitions that are out there go on to say often difficult to put into words or can't be written down, which is an interesting idea. And I think that's true for some things, but I think when it comes to casebooks, that's the whole point. We need to get these things down in writing. And tacit knowledge differs from explicit knowledge, which is knowledge that can be readily articulated, codified, stored, accessed, and easily transmitted. And it's the explicit knowledge that we typically think of when we're trying to disseminate information. So I came across this figure in the Twitter sphere, and I think it nicely showed that, you know, the codified knowledge is the practice guidelines, standard operating procedures, things that are out there, textbooks, those kinds of things. And the tacit knowledge is the untaught knowledge, the know-how. And it's really based on local settings and experience and practice and values, and can be hard to communicate. And the point of this slide was that where innovation and breakthroughs come from is not with explicit knowledge, but with tacit knowledge. So keep that in mind, perhaps as well. So some other terms to define: knowledge translation is the common term in Canada. Implementation in the UK, parts of Australia, the US, could be knowledge mobilization, but the notion of needing to close the know-do gap. So what we know from research and evidence and what we do in everyday life, and when those two are not aligned, we need to figure out ways to reduce that gap. So that's what I'm meaning by implementation, or the pathway or bridge between discovery and impact. And integrated knowledge translation is a Canadian term, also goes by research co-production, mode 2 knowledge production, could be participatory action research. All of these have things more in common than differ. But this definition is the one that we often use: a model of collaborative research where researchers work with knowledge users to identify a problem and have the ability or authority to implement the research recommendations. So the thesis of the talk. So when we think about knowledge translation or integrated knowledge translation, that tacit knowledge, that know-how, often relates to the mechanisms that make partnerships work, the relational aspects of influencing decision-making and change, the experiential learnings, those tips and tricks that people figure out as they're trying to make implementation strategies work. So the argument is, by sharing and synthesizing the experiential and tacit implementation knowledge, it can become explicit and therefore used to improve implementation efforts, which will lead to greater impact. And that casebooks, KT casebooks, are one small way of potentially doing this. So what are they, casebooks? Well, they're essentially a collection of stories on a theme, and they're often intended to provide insights into the real world experiences that people may be having, create better understanding of phenomena, make knowledge more accessible to more audiences, promote know-how, activities, and impacts. When we think of KT or implementation casebook specifically, the objectives are often to recognize and encourage KT activity, share concrete KT experiences, the successful and unsuccessful, for capacity building and stakeholder outreach. We've tried really hard for many years to get people to write about unsuccessful cases, and they won't do it. Part of that may be the embarrassment of not actually being successful. I'm not entirely sure, but I think we would learn a lot if people were brave enough to talk about when things didn't work out right. Gathering and sharing best and promising practices, and promoting and nurturing knowledge translation for impact. Identifying factors related to successful implementation and or application of health research in various contexts, and demonstrating the impact of implementation research evidence. And so where I started and became aware of it was in 2005, and one of the Canadian Institutes of Health Research Institutes, the Institute for Health Services and Policy Research, actually had a call for knowledge translation stories. And we were selected to have our story included in the casebook. And what we found, we had just done a study looking at the implementation of wound healing interventions to improve wound healing. We showed that we could increase healing rates and reduce the cost. We sent off the publication saying how the use of a guideline actually had these positive impacts, which were great. And then we explained why we thought how we approached the project actually made a difference. And the journal editor actually said, not interested, take it all out. We only want to know what was the effect of the intervention. And so this casebook allowed us to actually talk about what we thought were the causal factors of working in a collaborative way, and making sure that all of the stakeholders were involved, how we worked with the stakeholders, for example. And so that was my beginning of starting to think about casebooks and their potential value. And then shortly after that, the next year, I was actually seconded to CIHR in the role of the Vice President of Knowledge Translation, and wanted to advance the notion of casebooks. And we did the first one, which was a knowledge translation casebook, and then started to develop kind of operating procedures, a manual for how to do it. And then we created another one, which was the end of grant knowledge translation casebook. And then the idea grew to other parts of CIHR. There was a partnership casebook and a citizen engagement casebook. And the Institute for Population and Public Health, in collaboration with the Canadian Institute for Health Information, created one on population health intervention research. And then the Institute for Gender and Health produced one on a casebook for sex and gender and health research. And then the Public Health Agency of Canada decided to do a casebook as well. And then the Canadian Agency for Against Cancer, Program Against Cancer, Partnership Against Cancer created one, and research projects started creating them. And then this is a provincial research unit, produced a KT casebook as well. So it just sort of happened that all of these different groups started wanting to write and did write casebooks. And it actually went abroad as well. This is the, in the United States, the Center for Knowledge Translation for Disability and Rehabilitation Research. And you can see they're up to 8 editions of their casebook, really slick. You go on, you click on it, they come up. You can see them. And in the UK, the South Yorkshire Clark, which was Collaborations for Leadership for Applied Health Research, and I forget what the last C stands for, saw our casebooks and asked if they could produce one. And we said, yes, sure, go ahead. We're happy to share. And we shared our know-how, the tacit knowledge about producing casebooks. And then they went ahead and actually codified that information and created a toolkit for developing a knowledge translation casebook, and actually has, you know, these are the steps and described how they did it. And we have shared the manual, the toolkit, with lots of organizations who've been interested in producing their own KT casebook. So what are the key elements if you're producing one of these casebooks? Well, you need to figure out what the theme is, what the scope, what the specific objectives of the casebook are. You need to think about the audiences. Is it only for researchers? Or is it for the public? Is it for funders? Is it for decision makers? Is it for the academy? Is it for the media? Who exactly is your audience or multiple audiences? How are you going to get the cases? Are you going to invite people to write them, or are you going to have a competitive process? We found out very early, if you're working with researchers, they like the competitive process because they're very competitive, and they like to be the ones who get selected because that means they're better than the people who didn't get selected. And that's sometimes a motivating factor for researchers. You need to think about things like the length of the cases, the format, the content, all of these things you need to plan ahead of time. The development team. So we always have a project lead. We don't always have a working group or an advisory group, but depending on what your needs are, you may think of that. Do you need a committee that's going to be the peer review and selection committee? Do you want a writer and an editor? With the CIHR casebooks, we actually did hire a writer who would work with the authors to polish their work. And then we had an editor who edited everything so that it was had a similar look and feel. You need to think about production. So the design and the layout, the e-version, do you need a print version? The budget. Everything always costs something. You need those considerations. You need to be thinking about how you're going to promote and disseminate the product. And then you also probably should think about feedback and evaluation so that you can improve your product if you plan to do it again in the future. So what are some of the challenges? So you do require resources, either people or money. I'll tell you about the network that I currently am involved with, the Integrated Knowledge Translation Network. And so we don't produce a printed version. At CIHR we did, and there's pros and cons to both. Another challenge is the authors are sometimes wedded to academic writing styles. That's what they're familiar with. So they want to focus on their findings while you may want the case to be focused on process. And we've also run into authors who find it very difficult to say things in simple ways. They like to use jargon. And so the editing becomes really important. Some authors may need help to reflect on what they actually did. And so the relational elements, they may not even appreciate that. They can tell you the story of who was involved. And in our case, we wanted to know how people were involved and how they make things work. And sometimes some of the authors didn't actually think about it. They did it intuitively. And so we had to kind of encourage them to reflect and pull it out of them. The other thing to keep in mind, cases are usually short, and so you have to trade off the depth and the richness of the case with something that's going to be short and easily and quickly readable. What are some of the potential benefits or values? Well, casebooks can increase awareness of some of the less visible aspects of research and knowledge translation. And ideally, if it's done with accessible language, it means that more people can actually learn about it. It provides an outlet for explaining activities and relationships that may not get into publications, as I told you how I became aware of and interested in casebooks. For organizations and authors, it can provide recognition and credibility for KT activities and the people involved. So at CIHR, one of the things that we were quite surprised at after we had produced the paper versions, and we sent several copies to all of the authors to thank them, several, 3 or 4 of them came back and said that they had taken the casebook to their dean. And for the first time, they thought that their dean had actually got a handle on the kind of research that they do. And so it was partly because CIHR had selected them and recognized that what they were doing was important to report on, but also because it was relatively short, they were able to read it and figure out what knowledge translation was about. Authors have also told us that they use it with prospective partners to actually show, you know, a new partner or someone who's considering being a partner, how they actually work, to allow the partner to decide whether whether the relationship might be a good fit with them. And another thing that we hadn't anticipated at CIHR was it actually attracts visitors to the website. And it was the IT department actually said they noticed increased traffic to our casebooks. And so we didn't do it for that purpose, but we were quite pleased that people were finding them useful and coming to the websites. So a little bit about what's happened more recently. So I lead a multi-million-dollar CIHR Foundation grant called the Integrated Knowledge Translation Network that focuses on studying research co-production and building capacity of researchers and knowledge users to work in a collaborative kind of way. And one of the things we decided as a group was we would use casebooks to help share our knowledge and understanding of integrated knowledge translation. And in 2019, we actually launched the first one, and we've got 3 published, which are comprised of 25 cases. 15 of the cases are actually the first author, are trainees, and the 4th volume edition is currently under review. We were doing some of the peer review on that this morning, actually. So if you go to the website, you can see it up at the top here, iktrn.ohri.ca. Under the projects tab, you'll find the casebooks. The 3 casebooks are there. You click on them and they will come up. I'm going to give you an example from the 3rd edition, which was we asked trainees to talk about their experience doing research as a trainee using a co-production approach and what that was like. So we're actually learning. As I mentioned, we're now on to our 4th one. And so we've become much more strict about word limits. In the beginning, we kind of let people take as much space within limits. And then we realized that, in fact, encouraging people to stick to the 1,500 words forces them to be much more clearer in how they describe what it is that they do. We also, to get more consistency for the different sections of the case, we now give suggested lengths, and I'll show you that in a minute. And we're much more explicit in asking our questions. And so our questions to the authors of the cases has evolved over time as we realized we weren't quite necessarily getting what we had wanted. And so we asked about, tell us about your partnerships, and that was too vague. So now we're asking for, tell us about how you initiated your partnerships and tell us about maintaining your partnerships. And so I realized that this is really small, don't worry about it, but it's to show you this is the 4th call, how we've divided the case up into sections, and then within the sections we have questions or we ask the authors to describe certain things. And I'll just bring up, so the introduction, half a page, the partnership about 3 pages, but we want information on the initiation and maintenance of the partnership as well as the team members' roles. We want a page on the activities, the IKT activities. We want a page on the impact that the co-production activities have on the research project, and then we want about a half a page on lessons learned. So that's kind of the format that we're using right at the moment. So I'm now going to give you an example. So this comes, as I said, from the third casebook, and Dr. Conway reflected on her using an integrated KT approach when she was doing her PhD. And so I'm just going to read you a little bit of the story to give you a flavor of what it was like. It's about 3 minutes when I timed practicing it. So the case is about Dr. Conway's doctoral experience using an IKT approach when she worked as a clinical evidence-based information service specialist at a National Health Service hospital in the United Kingdom. And so the job involved partnering with point of care staff in the Women and Children's Division of a hospital to respond to their informational needs. So it was about bringing the information specialist to the point of care. She collaborated with them to bridge this evidence to practice gap by attending ward rounds and clinical handovers to identify evidence gaps, produce evidence summaries, assisted in developing new and updated clinical guidelines for them. She also coordinated evidence in practice group sessions in partnership with the healthcare providers, exploring evidence on topics and clinical queries chosen by the staff. And so her team consisted of the information specialist, Dr. Conway, 2 academic researchers, and then 5 knowledge users who were nurses and midwives, who were the implementation team members. And the implementation strategies they used for the project involved 6 group sessions over 9 months exploring evidence on clinical topics, a dedicated project website which acted as the repository for evidence and related information, and then the knowledge translation professional, Dr. Conway. And because of the IKT approach, the knowledge users identified the evidence relating to their practice and chose each of the 6 topics. The evaluation of the project involved following up with the implementation team to investigate whether evidence rounds had an impact on local policy and clinical practice at 3, 16, and 21 months after the final session. And they found that the evidence rounds actually had increased staff awareness of research evidence and local audit data, and had contributed to changes in medication labeling and updated staff guidance and changes in the management of preterm births. And most of the evidence was implemented by the 3rd round, so within the 21 months, which indicated the complex nature of health systems and the delay in the change process. So in terms of lessons learned about research co-production, despite informally discussing sustainability plans and proof that the impact of the project was there and willingness of the team to continue the initiative, the project didn't achieve sustainability without adequate funding and resources, which of course isn't that uncommon. But they also noted a benefit of the IKT approach was the ability for researchers to learn about the preferences of the staff for whom the intervention was intended. So for example, through discussions with the knowledge users on the team, the broader knowledge user engagement via focus groups and interviews in the project website, they essentially learned how staff wanted to receive information, and it was quite wide-ranging, and they were able to accommodate that because they knew that one size wouldn't fit all. So what would they do differently the next time around? So they have 3 important recommendations for trainee researchers thinking about using an IKT approach. So first, work with knowledge users who are early adopters, demonstrating enthusiasm from the start. So start with the people who want to play with you, and then welcome others to join for their own reasons as they're ready to do that. And they found that some individuals were reluctant to buy in to the evidence rounds during the initial planning phase, but later became important champions of the project. Second, leverage the team's networks to begin identifying potential knowledge users to join your project. The team identified the early adopters through a professor's professional connections, having worked in the hospital, and through word of mouth recommendations from the early adopters themselves. And third, invest a substantial amount of time in co-designing the project with the core team of knowledge users. and then involve the wider group of knowledge users as much as possible. And so Dr. Conway notes that the health systems are complex in terms of adoption and behavior change, and that the team appreciated all contributions and worked hard together towards the shared goal of improving patient care. The knowledge users were central to the IKT initiative because they were involved in the planning, the delivery, the decision-making processes, and ultimately the implementation of the evidence. And they found the IKT approach led to a very worthwhile and rewarding experience for them. So that gives you a bit of a sense of what the cases actually look like. And so what we typically do is ask someone to write a foreword and to synthesize the common themes or the interesting highlights from different cases. And Dr. Christine Cassidy, who actually had a case when she was doing her PhD in the first volume, wrote the foreword. And so this is her summary of the 6 cases that are in the trainees casebook. So they all talked about the positive impact of the IKT approach on the research process, on the study findings, and the trainee experience. The IKT partnerships with knowledge users facilitated the research process. The knowledge users contributed a valuable understanding of organizational policies and procedures and facilitated buy-in from the key members of the organization. The trainees writing the cases believed that the IKT approach added richness and relevance to their research findings and helped support the project's acceptability within the organization. By cultivating meaningful partnerships throughout the research process, the IKT approach may contribute to supporting the sustainability of changes in the healthcare system. The IKT approach facilitated mutual learning for the trainee and the knowledge user partners and was described as worthwhile and rewarding experiences for the research trainees. But as with everything, there were challenges that were reported in the cases. For example, the health system partners have many competing priorities. The trainees had to find a balance of communication to keep people informed and engaged in the process without overloading them with information. There was a high level of turnover in many of the organizations, and this led to challenges of continued engagement and having to restart partnership development with new staff members as they came along. The need to be adaptable and flexible to address key health system issues and maintain relevance of the research. And so the notion of if you're working in an applied setting, things change quickly and you have to change with them. And they noted that when they already had pre-existing and well-established relationships, that was a bit easier to do than when it was with a new partnership. Considerable time and effort was needed to develop meaningful partnerships and encourage efficient collaborative research. And so taking the 6 cases collectively, there were a number of recommendations to other trainees thinking of using a co-production approach. So research partnership development and maintenance is critical. It's important to invest time to plan, communicate, listen, and work together. The trainees recommended a flexible and adaptable approach to support health system partners and adapt as needed based on their context. Many of the trainees encouraged others to monitor and evaluate their IKT approach. So in these cases, they hadn't built into their studies actually studying the relationships and the partnerships, and they were suggesting that as trainees start to use an IKT approach, they actually build that into it so that we can advance the science of integrated knowledge translation or research co-production, and enjoy the enriching process of mutual learning and exchange with health system partners. And I'll just give you a minute to let you read Dr. Cassidy's summation for the cases. So there's a number of different ways that different organizations have used casebooks. And so I wouldn't want you to take away the idea that we're suggesting there's only one way to do it. I think you need to figure that out if you're planning to develop casebooks to work with all of your knowledge users and potentially researchers to figure out what the best approach is. So if we think about casebooks as a promising concept, there are a few areas that I think we do need more work. So we need to start doing formal synthesis of cases to generate more generalizable knowledge about the IKT strategies and how they work and under what conditions. And we actually have started a project with our will be four casebooks, where we plan to do that using more a realist approach to understand from the cases. And then to also identify the gaps so that we can start changing the nature of the cases and what we're asking for to fill in some of those gaps. We need, I think, formal research on the value and benefits of casebooks and how they contribute to evidence-based healthcare. We haven't done this as well as we should have, although I'm not sure in terms of being an intervention, the downsides I think are pretty low. I don't think casebooks have the potential for much harm, but that doesn't mean we shouldn't evaluate them more thoroughly. And we need to think about better understanding the use of casebooks as a teaching tool. And Dr. Anita Katari is actually using them in a KT course where she has her students select cases from the casebook and then write case notes on them. And the case notes are to try to integrate the literature that may be out there, theories, models, and frameworks that may be relevant. So getting the students to think more carefully about the actual cases and then how they may or may not be reflected in the literature. So we've pretty near come to an end. I want to remind you of the objective, and hopefully the presentation has encouraged you to think a little bit more about the need for and the value of transforming tacit knowledge about implementation and impact into explicit knowledge so that we can better influence practice and policy. So next time you see a call for a casebook, think about submitting your own case. Check us out. There's the link to our casebooks. If you follow either the IKTRN network or me on Twitter, whenever we post calls, we announce them on Twitter. So that would be a way you could find out about our calls. So I want to thank you now for listening to this presentation. And again, I'll wish you a happy World Evidence-Based Healthcare Day.
Thank you so much for that, Ian. That's a fascinating talk. It's engendered a lot of good, positive discussion in the chat and some really key questions as well. It'll be great to get to those, but what I forgot to say at the beginning is we'll do questions combined at the end, bring it all together in that question answer scenario. But what I'd like to do right now is to introduce our next speaker, who is Bianca Pilla. Bianca is the Global Relations Manager for JBI. She manages partners with over 70 different universities and health facilities across 40 countries. Quite a small, modest job, as you could tell. Her expertise is in multi-stakeholder partnerships and development at global, national, and community levels. She has expertise in communications, policy development, and program evaluation. With a background in international development, Bianca has led numerous projects across diverse fields, tertiary vocational education and training, community health, livelihood, gender, and disability services. So it's my pleasure to invite Bianca to now take control of the presentation and take us forward through the rest of this session.
Wonderful. Thank you, Craig. And thank you to Professor Ian for that presentation. As you can see, the wealth of knowledge which we were able to build on, which I'm going to talk you through today. So in my brief presentation, I will be speaking about JBI's experience in working with our international collaboration to highlight the impact of JBI's approach to evidence-based healthcare through impact stories. I'll do this by touching on the impetus for this project in relation to our mission and vision, why we chose to do this via impact stories, some of the discourse around demonstrating impact. I'll then also walk you through our process and provide an example, and finally discuss some of the feedback from the authors involved and takeaways should you wish to create your own impact story. So the need or importance for JBI to highlight the impact of its work in evidence-based healthcare is because we are a mission and driven organisation. For 25 years, JBI and its international collaboration have been driving improvements in the quality and outcomes of healthcare by promoting and supporting the synthesis, transfer and implementation of evidence into clinical practice. JBI has a unique approach to EBHC that encompasses a multitude of programs, products and partnerships that aim to empower healthcare professionals to implement and sustain evidence-based healthcare to improve health outcomes. Now, the widespread impact of JBI, both in Australia and worldwide, is attributable to our global partnerships that ensure that evidence-based activities are context-specific, driven by individuals and groups that understand their unique health environments. We have formal partnerships with almost 80 universities, hospitals and NGOs worldwide who each lead evidence-based initiatives in their community or region, directed by the knowledge leads of local clinicians and consumers. Known as the JBI Collaboration or the JBIC, we often refer to them as the engine that drives our worldwide effort to achieve our collective vision. So for more than a decade, we have been monitoring and evaluating the outputs of our collaborating partners. This includes JBI systematic reviews published, evidence synthesis and implementation training conducted, JBI implementation projects completed. However, rarely do we know what came next. What did they contribute? Did they contribute to changes in policy and practice? Were the implementation projects successful? Were they sustained? Were they scaled up? If they did contribute to change, what were the drivers of those change? And these are the questions that our advisory committee would ask year after year, including Professor Graham, who was a long-serving member, as he acknowledged, in relation to the impact of JBI's work and the work of our collaborating partners and whether we were achieving our mission and vision. So we met with Ian several times and we were encouraged by him to capitalise on his experience and experience of all the different research institutes that he noted in his presentation to demonstrate and explore the experience gained with our collaborating entities in promoting and supporting evidence-based healthcare. So why impact stories? Now, first I should acknowledge that, like a lot of things in evidence-based healthcare, there are numerous terms or names for different types of stories that document change. There are case stories, impact stories, stories of change, most significant stories. While they all have their nuances, essentially they are a narrative approach to documenting and discussing change. And stories are popular for a reason. They are personal, they bring information to life, they can break down barriers by increasing empathy and understanding in the reader. And this is because the story moves beyond research findings and allows the readers to connect and immerse themselves into it. Stories combine events, facts, experiences with a personal narrative in the context of specific situations. And all of this can make information more accessible and communicate to a broader audience, as Ian acknowledged. So impact stories tap into the knowledge of practitioners. Again, as Ian noted, they gain this through a reflection on their own experiences and environments. It asks them to reflect on the importance of context and the impact on long-term outcomes, highlighting barriers, facilitators, lessons learned both at an individual and organisational level. And most importantly, it helps to communicate change and the significance of this change. So while an impact story, which is essentially a subjective narrative that discusses impact level results, should not be confused with more robust impact evaluation frameworks, insofar that they both aim to discuss and highlight impact, I think it's useful that we look at some of the discourse around demonstrating impact. Now, traditional impact assessment frameworks that consider a linear progression of inputs, for example, funding leading to activities such as research, leading to outputs such as guidelines and policy, outcomes, changes to practice, then leading to impact. these are increasingly viewed as overly simplistic. And this is because, as we all know, the evidence ecosystem is complex. It's an unstable network of people, technologies with different processes, individuals and organisations that doesn't always comply with this neat, ideal linear progression of inputs to outputs to outcomes to impact. Now, there are, however, emerging frameworks that adopt the concept of contribution rather than attribution, acknowledging this complexity and the non-linear factors that influence outcomes, including the transfer and implementation of research evidence. These contribution frameworks provide a practical way of looking at how research and knowledge translation activities interact with other drivers to create change, including the contextual factors that help or hinder impact. They also acknowledge that impact can be measured at various points, with opportunities for ongoing learnings, as opposed to the traditional view that impact of a project or intervention is only ever visible at the end of a pathway, which, as we know, can be very long and winding. So, taking this view of considering how JBI evidence synthesis, transfer and implementation activities contribute to impact, we developed a pilot project with our international collaboration to collect and publish impact stories about their JBI work. For this, we proposed that a JBI impact story should highlight how an activity, project or intervention informed by the JBI model of evidence-based healthcare contributed to changes in health policy, guidelines, clinical practice or health outcomes using a story-based narrative approach. So to do this, as Ian suggested, we formed a project team. It was very much learning by doing over the 12 months, and so this process definitely evolved. But in the first instance, we drew on the wealth of resources that Ian highlighted around case stories and case books. We modified some of the questions and methodology to focus on impact. We developed and tested these questions specific to the different program areas of JBI. Obviously, there's a big difference between our synthesis, transfer and implementation activities, and these required different questions to draw out the relevant information in relation to those program areas. We did create our own author guidelines for the narrative approach. And I think the biggest thing that we learned from this process is that it is absolutely an iterative process. So in the first instance, we tapped people on the shoulder where we knew of existing stories of change that had led to impact. However, a lot of our authors are very academic in their approach to this, reporting on the problem, the intervention and the results. And we found that we needed to conduct interviews, have further questioning, ask the same question in 5 different ways to really draw out that tacit knowledge and to be able to help them get that onto paper. So I'm going to walk through one example, which we have published on our website to give you an idea or a flavour of a JBI impact story. So this is from Yani Wu, who is an advanced research nurse at Nanfang Tertiary Teaching Hospital in China, who established a 6-month evidence-based project as a part of JBI's evidence-based clinical fellowship program. Her project aimed to normalise the pre-treatment assessment for patients with breast cancer undergoing chemotherapy to improve standard care in the hospital. In her story, Yani describes the deficits in standard care that led to establishing her implementation project, the side effects of chemotherapy drugs that can be amplified without correct patient assessment. She talks about using JBI's Getting Research into Practice approach, including the project initiatives and strategies employed, such as patient education, engaging with nurse and medical leaders, and the results that were achieved as a result of the project, including significant increases in compliance with the evidence-based audit criteria, including 9 out of 12 criteria that increased from 0% compliance at baseline to 90% post-intervention. She talks about how this change was sustained over time and the ways that they sustained that. But what moves this story from an academic reporting of data and discussion of results to an impact story, as I've described thus far, is her reflection on the keys to success. statements from interviews from nurse leaders about the perceived benefits of the program, and a discussion about how the change has been sustained over time, leading to opportunities for scaling up the initiative. So I'm going to provide a quote here from the story where Yanni interviewed a nurse leader who said, "In the past 2 years, several benefits have been obtained from this project. In addition to the improvement of nurses' knowledge and the standardisation of chemotherapeutic nursing practices, a significant change has been the increased communication between nurses and patients through standardised evaluation. There are nearly 250 patients receiving chemotherapy every month. Over the past 2 years, nearly 10% of patients have been identified as having psychological problems through the psychosocial assessment established in this project, and as a result have received psychotherapy in a timely manner. In the past, we relied on patients or their family members to voluntarily report and seek psychological help during chemotherapy treatment." So in the quote displayed here, which I'll allow you to read, Yanni discusses the unintended impact of nurses involved in delivering evidence-based practice and how it's contributing to improved care more broadly. Now, these are the sorts of things that in an academic paper wouldn't be discussed because it didn't directly relate to the audit criteria of the project. Nonetheless, it's an unintended or perhaps intended outcome and impact which, Yanni and her team see as integral to the success of this project, and in terms of undertaking EBP activities more broadly in the hospital, which I think is an important insight that has come to light as a result. So Yanni concludes her story with highlighting how the project's success over the past 2 years has led to receiving funding from the Guangdong Health Commission to roll out the project into 20 hospitals across the province, training at least 1,000 primary nurses. And in Yanni's words, this funding will ensure that we sustain, scale up and disseminate the success of this implementation project to ensure the best health outcomes for patients with breast cancer across Guangdong province. Now, this is a very brief summary of just one story. However, over the past 12 months, JBI has worked with more than 25 individuals and groups from the JBI Collaboration. When viewed cumulatively, these impact stories provide a rich insight into how different individuals and organisations have adopted JBI's approach to evidence-based healthcare, what has changed and how, the positive, contextual and challenging experiences and outcomes, and the lessons learned from their work in EBHC. Most importantly, however, they capture and amplify the voices of those individuals working to improve health outcomes worldwide through EBHC. Now, when we surveyed authors about their experience in developing their impact story and the value of stories as a mechanism to communicate the impact of their work, responses from authors highlighted how the process of personal reflection, of interviewing colleagues, patients and stakeholders was valuable in and of itself to deepen their understanding of why they did the project, how they tackled it, what they learned, what others learned, and the extent to which their work had contributed to change. Other responses related to the opportunities that the publication and dissemination of these stories have led to. So in her feedback, Yanni noted that their impact stories have been downloaded over 10,000 times via WeChat, and that in her opinion, this dissemination has been a great mechanism to introduce EBP and raise awareness about the value of EBP amongst nurses in China, particularly those without a research background. For many of our partners in low resource settings who struggle with institutional support for undertaking EBP activities, the feedback has been that the publication of their stories on JBI's website is seen as international recognition of their work and has been used successfully as an advocacy tool for local recognition and has led to funding opportunities. And this is a little bit, this is similar to what Ian said in terms of being able to take a accessible, an accessible story to people within their institution to build that advocacy and understanding of what they're doing is really important. So takeaways. Now, this is very similar to what Ian went through, but I think it's important to be clear about your purpose. Now, our purpose was demonstrating the impact of JBI's approach to evidence-based healthcare. The purpose of many of the case stories and case books that Ian went through are different. And I think Ian highlighted this, that there is no one singular approach as to how to use case stories or impact stories or stories of change. But I think it is really clear to be about that. It's important to be clear about your purpose. So is your aim to educate an audience about programs and approach and successes? You could convey the importance of a particular intervention. There might be a need to convey the complexity of a particular issue and persuade policymakers to consider a wider range of views. And so this leads into knowing who your audience is. And like with Yanni's story, if you're hoping to use this to introduce EBP to a new audience, then your language should be mindful of that, particularly your use of jargon. Employing narrative techniques is easier said than done. And I do implore you to go and have a look at the wealth of resources out there, and the toolkit is especially useful, because a good story, if it's going to be compelling, if it's going to draw the reader in, if it's going to provide the information in a way that is accessible, it needs to define relationships. It does need to have a sequence of events, introduce the problem, barriers of change, lessons learned, and most importantly, it needs to use stakeholder voices, because these are all the elements that are going to be remembered as a complex whole. Now, as we've noted several times throughout this presentation, it is World Evidence-Based Healthcare Day. So I'd like to wrap up highlighting how this is a global initiative that raises the awareness of the need for better evidence to inform healthcare policy, practice and decision making. And the theme for this year is From Evidence to Impact. And this was inspired in part by JBI's experience in using impact stories to demonstrate the impact of JBI's approach globally. And so we joined with 7 global leaders in evidence-based healthcare and led a call to the global evidence community to share their impact stories to spotlight the global impact of EBHC on health research, policy, practice, and health outcomes. Now, if you go to worldebhcday.org, you can read 35 impact stories from 20 countries and numerous organisations and networks, including the Red Cross, the George Institute, NICE, Cochrane, Centre for Evidence-Based Healthcare, and of course, the JBI Collaboration. Now, whilst it is too late to submit an impact story for World EBHC Day, we are encouraging people to share their stories via Twitter using a Twitter thread. There are great resources on the World EBHC Day on how you can share your impact story via a Twitter thread on Twitter. So we hope you do get engaged and follow the World EBHC Day Twitter account as well. To conclude, I always like a quote, and today I'll be quoting JBI's Executive Director, Professor Zoe Jordan. Our lives have purpose, our stories are important, our voices matter. Let's make an impact on health outcomes this World EBHC Day. So I will conclude there. I'm going to hand back over to Craig so he can help us through the questions that you all have.
Thank you so much. Ian, if you could unmute your microphone as well, that's awesome. Thank you very much. So we've had great chat and some really good questions. The first one was, can patients create casebooks?
Yeah, I think for sure. And I think there's different ways to do it. And so what I was presenting was the written version. Another way to be doing it could be with digital storytelling. And so healthexperiences.ca, we actually have a project with them. They typically interview patients about their illness and then use those interviews to create discussions with healthcare providers or with patients for that matter. And one of the series that they've done is patients working on teams with researchers, and what's that experience been like for them, and what have been the challenges and what's been rewarding for them. And so you can actually see, I don't know if they're up on the web yet, but I've seen several of them. And so that is actually more, I think, has more impact than the written version, because you actually get to see the person, you can hear them, you get a sense of what they're like and what they're passionate about, or what the challenges were, or whatever. So the basic answer is yes. I think patients can easily think of different ways. I think it's important that groups that may be more comfortable with oral tradition, we use videos and digital storytelling to make sure that we capture their stories. Those that like to write and want to write, we can use that experience. And I just wanted to follow up with one of the things that Bianca said, which was so important, and we learned it too, is that iterative nature. And even with researchers who often do like to write, but not in this format, we've had to do that same thing of actually kind of interrogating them about what they've said, to pull out from them, because they're not thinking in the lines of a story. And so sometimes I wonder if it might not be easier to send someone to interview them, ask them the questions, get them to reflect, ask them some more probing questions, and then write it up and take it back to them. So I think we need to kind of think outside the box, and that there's different ways, but it's about getting the story.
Absolutely agree.
Okay, great. Look, I should acknowledge we're going to go a few minutes over time because the questions are key. So if you need to leave, thank you for having been with us this morning, but I'll roll on with the questions now. There's a few patient-centered questions, which I know will appeal strongly to you both. The next question, which is kind of a follow-on from there, is what does evaluation of casebooks potentially look like when we know that patients and practitioners often have different values or different priorities? So how do you plan or manage evaluation in that context?
So I think this goes back to Bianca's point about being really clear about what the objective of the case or the stories are. That's where you need to start with. And that will set the direction for the evaluation of what you're wanting to find out, but you also need to be prepared and look for unintended consequences or the effect on potentially different audiences that you weren't actually thinking about when you produced it.
Yeah.
We also had some of our authors validate their stories with their patient groups. So before they submitted it to us, they formed, a group with 3 or 4 patients who were part of the ongoing implementation process, and got their opinions. So there are a few stories that have the patient voices in them that went through that validation process, which I think, depending on where you're at with your project, what your project's like, whether there's ethics involved as well, but that can be a useful tool.
Awesome.
And because we're interested in research co-production, we actually encourage the authors to think about including all of the knowledge users on the authorship team. So it's not just the researchers saying, what the patients think or what the health system leaders were thinking or what they did, but actually include them in the project and as authors.
Yeah, which you've recently done, Ian. You've published a couple of papers recently where citizens are lead authors. One of the questions was, what would be the ideal evaluation method for casebooks if you wanted to demonstrate impact?
Yeah, that's a really, do you want to take that one, Bianca?
As we say in Australia, I'm happy to handball that one to you. I think you acknowledged, Ian, that this is actually a further area of work to do. So, we've employed impact stories as kind of a high level evaluation tool to then evaluate the evaluation. I'm not sure that we have thought that far ahead, and I'm happy to acknowledge that.
Let's roll through then, because I've got a couple more questions I really want to get to.
Sure.
I mean, as health professionals and people that work in EBHC, we're all careful about and mindful of patient confidentiality and anonymity, are there guidelines and processes written into the casebook methods that help to protect patients in this discovery process?
The guidance, the toolkit from the Sheffield group do include ethical considerations. And so privacy and confidentiality, like obviously it depends on what the story is about and who you're invoking in those stories. So I don't think there are, you know, established in stone standards for it, but that is an important consideration anytime you're writing about what your group has done. You need to be sensitive to, are people going to be sensitive to being identified, even if they're not identified by name? Other people reading the story from their setting will know who that person is you're referring to. So that is something that needs to be considered always.
Yep. And I want to finish on one for the researchers online, which was, how do you persuade funders to support a casebook proposal?
Yeah, so at CIHR, it was actually quite easy because, and as I mentioned, we had multiple goals. So one was to highlight the great work that was going out that some of us knew about because researchers were telling us about it, but for the most part, the organization was unaware of it. So this was a really useful thing. When we then had, you know, a paper version, a hard copy, and the president of the funding agency was getting a note from the dean of a faculty somewhere saying, this is really great, thanks for highlighting one of our researchers, that just reintroduced the notion of maybe we're onto something here if we're getting people telling us that they like this and they like being acknowledged. So very similar to some of the quotes that Bianca mentioned, the credibility that's then lent to the authors by the organization that's publishing the casebook is really powerful, and we hadn't anticipated that at all.
Right, that's awesome. Look, I think we'll close questions there. If you want to ask more questions or have more discussion, use the Twitter chat, use the @handles for Bianca and for Ian Graham as well. Thank you so much for joining us today. If you want to know more about what we do, how we do it, and why we do it, check out our educational website. If you're looking for more opportunities to engage with videos and podcasts, etc., check out the YouTube channel. It's important to us that we can learn from this experience with you. So there will be some feedback coming out. Please do help us by completing that feedback evaluation form as well. And just to let you know that the next webinar is for the systematic reviewers and synthesis scientists. Associate Professor Ed Aramataris will be speaking on the JBI Systematic Review Toolkit, which is used across the world, across 70+ centres and 40 other groups. So we look forward to sharing that with you and again, engaging as a global community for evidence-based healthcare. And thank you so much for your time again today. We appreciate that you've been here with us. Thanks, everybody.
Bye from Canada.
Thank you.